medical physicists, PhDs, and the necessary staff. This is a group of the medical physics group, also PhDs and technicians. This should show you the surrounding of how we have, what is our usage and what is the benefit from the book of Dr. Khan regarding the physics of radiation therapy. Let me quote text here from the 6th edition. This is the newest one. A vital reference for the entire radiation oncology team. Khan's The Physics of Radiation Therapy thoroughly covers the physics and practical clinical application of advanced radiation therapy.
Sorry to disturb you, sir. Your sound is distorting a bit, and I think it's need improvement.
Is it better now? Should I speak louder?
Yeah, it's better now.
Okay, let's try. So the new editor, Dr. Gibbons, of the 6th edition carries on the radiation established by Khan in previous editions, ensuring that the 6th edition provides state-of-the-art information for radiation oncologists, medical physicists, dosimetrists, radiation therapists, and residents alike. This updated classic remains the most practical radiation therapy physics text available, offering an ideal balance between theory and clinical application. There is nothing more to add from my side in this regard. And I thank personally Dr. Khan for this continuing support over the last edition. The Department of Radiation Therapy the clinical part is we have 4 machines on site here, and we have 2 satellites for the we have 2 satellites with 2 machines. We have connected everything by the we have Electra machines, and they are connected by the mosaic, and we are completely film paperless since 10 years. So the historic development of IMRT, VMAT IGRT starts at April 2002 with the step and shoot technique. We have shoot technique. The treatment machine was a Siemens Megatron KD2, and the R&D system was Siemens Lantis, and the treatment planning systems were precise plan from Electra and Corbus from Nomos. You see, these are examples of those distribution out of this period. But all systems were more or less standalone systems. The integration of these systems were poor at some point. So there was a lot of control, and the general procedure at that time was we have to, after the treatment plan, we have manual control of segment shape and monitor units per segment. We have verification of LINAC generated intensity matrices during actual treatment. So we control the delivery, verification of target point by port films during the treatment course, always verification of target point by port films, superposition of intensity matrix on patient silhouette. So you can see this is what we have done. You see it here. We put on the tray hold. We use tray hold mounted films to control that the machine delivered what the treatment planning systems, what the treatment planning system calculated. And this is a superimposed DRR with the intensity map. So we want to have an idea what gets delivered. Is there something missing in these things? The inverse planning, this is where everybody starts with. That means the user enters port and arc layout and treatment objectives, and the computer optimizes the beams. And the key of inverse planning for the physicians is a prescription tool that easily and efficiently captures the physician's most critical critical clinical judgments. So as you know, this the IMRT fluence map is done by the optimizer, and the leaf sequencers converts these fluence maps into MLC leaf positions versus monitor units, and this is the classic step and shoot approach. So the delivery options are, as I said, at the beginning, the step and shoot approach. That means this was a static delivery, and no moving parts during beam on, leaf positions during beam pauses. The standard MLC dynamic was a window technique. That means the leaves are moving during one time, and the next step was the sliding window technique, and the gantry is moving during beam on. We used, but you know, these MLC types, especially this MLC from the Siemens Mevatron, was the leaf width was 1 cm in the ISO center. So in 2004, we introduced the Mimic from the Nomos company. This was an add-on device. You see here. This was added on to attached to the machine's head, and you have individual leaf controls, and you have 0 or 1. That means you have a very deep modulation, because you have the maximum. This is the maximum grade of modulation uses by this type of modulator. And this modulator delivers by this opening and closes the sleeves during the rotation, and then you can move the patient stepwise, and this is a kind of sliced delivery of each gantry rotation. This took per target. This took roughly 1 hour. So, and in that case, and this is very the same thing like the binary multi-leaf collimator. You know this from the Tomotherapy. Hopefully you could see this movie. I have taken at the Astro from this collimator. You see there is only 0 or 1. That means you could deliver a very high modulation. There is no moving of leaves within the treatment, and this is a advantage of this method. So, and this is set up 2004 for SRS treatment with the Mimic. And you see, you have to mount, you have to prepare the machine itself. You have to do some checks for the commissioning. And I will come later on to the main questions question of my presentation. Is we have to minimize. I told you 1 hour per target. So we have to control the intrafractional movement. So we have a maximum of fixation of the patient. To this point, I will come later. So, and what were the lessons learned during the?
Sir, sorry to disturb you again. Your voice is quite distorted. Number of participants are saying that voice is not clear, and there is a distortion in the voice.
Is it better now?
Yes, it's better.
Oh, thank you. I switched the microphone. During the commissioning, you see what we have learned at that time. MLCs basically MLCs were constructed for shaping irregular fields. At the beginning of these of the Megatron KD2, they were not intended that you deliver intensity modulated beams. So in that case, a main issue were the calibration of this mechanically calibrated MLC. And you see this, what we have done, let's say, on regular basis before every patient when we treat the patient QA plan. You see, we have to check the modulation, the calibration, and you see here the bad calibration, and you see here the good calibration. Also, the QA plans in general based on film dosimetry. So you see, always we identify issues in terms of the not sufficient. The MLC calibration was not sufficient for the IMRT. In that case, you had a long and intensive test and QA part before you can treat a patient, and also you have to intensify your QA of the machine calibration. You see this typical fence test. You see here the bed calibration here as well. And of course, everybody who stepped in the first time for film dosimetry knows how long does it take to have a really good chain for film dosimetry available. We put in a lot of effort and a lot of work in the film dosimetry, and in that case, when we switched to the 2D arrays, we had a long. We need time to have all this training for film dosimetry a bit behind. We were focused on resolution issues and these things. So this were, for example, never an issue for film dosimetry. And in this commission, I made one remark that the parts of the delivery chain were more or less single parts and were not very well integrated. So what were the lessons learned about this single part connections? There was a communication between RNV system and the LINAC. RNV record segments which were not irradiated. RNV system doesn't record segments which were irradiated. RNV record segments of another patient. So these are serious issues, and in that case, it took a while until we have the whole chain. We have the whole chain working, and what is more important, that you trust this chain. The lessons learned and now coming to this little tool. Also, the treatment planning systems were not prepared to deliver this intensity modulated the segments and the segment shaping and the sequence of these segments. So, for example, one system allowed is that you move the collimator between beams. This is, for example, for such a setting with the patient in position is not acceptable, and this is a block to be sure that you will have no collimator movement during the application. So we block the collimator mechanically. Another thing was the TKFZ TPS planning system called Conrad. It was an own development of the TKFZ. This system were not able to mirror surrounding leaves for the Electra machines. So this were a lot of lessons learned during this period, but we had a increasing number of the IMRT treatments in this time. And if you look at the historic evolution of radiation therapy over the last 30 years, the whole development is referenced to a reduction of normal tissue dose. This is the main goal, and I come to one of the main aspects of my presentation is what's about the margins. Reduction of normal tissue dose means you have to have minimized the margins. You have to have minimized the margins, and margins are caused by target definition. So what's about the imaging? It means about the diagnostic, the histology. Are they used standard protocols and these things, standard protocols for the target definition? These questions. You have interfraction motion. You have to take into account that you have interfraction motion. That means motion between fractions. You have intrafraction motion, motion within a fraction. And you have the block of treatment planning and treatment machines. This is covered by commissioning and quality assurance. Maybe this is a central responsibility of the medical physicist. But if you are involved in the clinical work today, you have to have an eye on the others as well. These definitions of the targets and of the volumes are the standard reports, are the ICRU reports 50, 83, and 91, and you have standard recommendations for volume definitions, those prescription and reference points, those normalization concepts, and those reporting and evaluation. This is ICRU volume. You see, this is from the ICRU 29 is from 1978. We have in the next ICRU 50 were the 1993, and the newest one is the ICRU 83 2010. And this is amendment to the ICRU 50. So you have the main volumes are the GTV, the gross tumor volumes, the CTV, clinical target volumes, the ETV, the internal target volume, and the PTV. The gross tumor volume means this is a primary tumor, including lymph nodes, lymphatic pathways, metastasis. And here we have to talk about diagnostic approaches, visual inspection, palpation, endoscopy, X-ray, CT, MR, all these diagnostic images, they are available to cover and to define the CTV. The GTV. The CTV includes single malignant cells, small cell clusters, microformations, non-detected tumor cells, and this means you have to have a knowledge about including what's the potential of cell propagation. Maybe this may require boost volumes, and you have frequently more than one CTV. The planning target volume. The planning target volume is a geometrical concept, and this geometrical concept is defined to select appropriate beam size arrangements, taking into account the net effect of all possible geometric variations and inaccuracies in order to ensure that the prescribed dose is actually absorbed in the PTV. So the normalization, the dose, the prescribed dose has to be delivered to the PTV. That's the effect. The geometry, and you have to take into account geometrical patient changes in regard to the treatment planning system. This is depending on changes, weight loss, tumor shrink. Then we do if we have significant changes here, we do a new treatment planning system. Of course, you have organ motion, respiration, pulse, patient positioning in reference to the planning CT, patient motion during radiotherapy, intrafractional organ motion, bladder and rectum filling. That means interfractional organ motion. What are my margins? And this is the main aspect. How large could those margins be? And this is we are doing IMRT and VMAT courses international, and these are always essential questions. What are the margins? What are our margins? But it's very difficult to transfer margins from one place to another. Start with the target definition by imaging. These are treatment plans out of our patient treatment, and at that point, when more and more the PET-CT comes into account for the imaging, we saw that this is a patient treated with a prostate case, and in addition to the CT, the PET-CT shows suspect lymph nodes in this area. So in this case, we had a development in the direction that we are in a position that we expand the standard treatment for the prostate and take this to lymph nodes directly into account. The other things are, when we are defined this head and neck case, when you make an image fusion with this case, you see are these suspect areas from the PET-CT included in the PTV. And these images and these imaging parts is advancing, and it started with the image fusion of CT and MR images for the SRS treatment, and this come into account. Next step was MR images, and then you have an optical an optical visualization by the PET-CT, and then you can at the end you improve your diagnostic knowledge for the CTV. And this is one thing that I got out of the ISTRO 2021. The GE is able to make a 3-modality fusion, MRI, PET, and CT, and you see the direction for the definition of the CTV. In our case, we got access in December 2017 to a PET MR. This combines the 3 Tesla MR with the PET, and therefore you have directly a fusion of the PET and the MR images, and then you see a lot of information. For example, in this area here, or in this area here, you see what is the impact for your definition of the CTV. And this advanced image diagnostic is also approaching, and you see here, and this was the last thing I checked out. This are image analysis. At the end it's a pattern. It's an analysis of pattern, and you see, but they were able to detect and classify these suspect areas. And you see here they were able. This is a classic urologist classification, and you see the direction in the area of artificial intelligence is what is the preparation, how can the definition of the CTV can improve. So in January 2002, we got access to the photon counting CT, and the the idea from the very beginning was we want to use this this CT for lung cancer screening, and you see it here. The idea is you have a standard acquisition. You have the screening procedures in other areas, mammography screening and these things. So you have the patient acquisition is not by some symptoms. The patient acquisition normally is to say, for example, the mammograms are done after a specified age, and you have to have, I think, every 2 years a mammogram. And here's the same one. If you have some including criteria, for example, pack years of smoking and so on, you can include this patient and then you can make a standardized image acquisition, automatic segmentation, and the quantitative image analysis, and then you could find out the typical shape, the typical texture, and the typical distribution in such a volume. And then you have an automatic analysis, and you can pick out the patients who have suspicious lung nodes. Yeah. Next point to minimize the margins is the interfraction motion. That's the classic 3D conformal 2D verification. Typical, you have drawn the laser position during the simulation or the planning CT. You have drawn the field contours on the patient, and you treat it. You see, this is here a very complex shape. You have different energies, different kind of radiation. So this is very hard to have. By every fraction, you have the same position, and you could cover the whole target. As a consequence, the margins for this type of verification, the margins has to be bigger, and the involved tissue volume for this bigger margins. I think how to observe this from fraction to fraction. This is the analog part by film, or the digital by port film, by electronic portal image devices. This is here. This is then included into the electronic systems. This is the analog. There is some improvement by markers to say, okay, I can do a 2D verification, and I see the markers, and then you can, of course, improve the interfraction motion, or you can minimize the interfraction motion, but you need, let's say, this step to be sure. One thing, what out of the clinical daily business, let's say, is this case, we have an increasing number of retreatments of patients, and these retreatments are often bony metastasis, and that means you have a very special point where the patient gets treated, and after that, in a retreated situation, we have this is the case for that, and you could understand this would be not possible with a 2D verification to hit by a single dose of 7 gray for 3 or 4 fractions this target. What about the intrafraction motion? That is the first answer to intrafraction motion was maximum patient fixation. You see, this was out of the DKFZ in Heidelberg. This were their first approach when they thought, you have seen this mask. This mask is wrapped for each patient, and the patient is captured in this mask for the whole therapy. So the movement inside this mask is maximum low. And the next step from the Heidelberg colleagues to go to the rest of the body, where okay, we try to cover the same principle from we transfer the same principle from the head to the body. And you see this for other cases, stereotactic cases, you see this kind of fixation is only to have the maximum fixation during the application. And as I said, the application time at this point were 1 hour. So to keep a patient fixed for 1 hour, you need this hard fixation. Otherwise, it wouldn't work. And this was expanded is trying to expand it to the whole patient. You know, maybe this body frame by this mechanical pressuring device. So this was at the beginning of this time. This is again. This is a stereotactic body frame to treat patients, for example, for the liver cases. And what we have done in 2006, our first Chromium CT was available. So we were able to do a patient positioning by 3D verification. So this is a mask we used so far. And then we made an internal evaluation and have a paper out in this for this transfer. We transferred this classic mask into what we call the frameless SRS for a standardized head and neck mask. So we had an improved version here. We need a better base frame here and these things. So, but we made an evaluation, and then we decided to say, okay, we will treat these patients, the SRS treatments in future with a standard mask, and the patient gets positioned by a 3D Chromium CT patient positioning. You see this here. This is a small target, and you see this is before positioning. And this is after positioning, and this is done on every single fraction. When we start with this approach, we have often the discussion. Really, you do really for each patient positioning a Chromium CT. What about the dose? Yeah, you minimize your margins. That means you block normal tissue from higher doses. And therefore, you have exposure an additional exposure by the Chromium CT. At that time, the discussion started a lot to a little or a little to a lot. This were the discussions in this area. So this were a standard. This were a standard in our case. The SRS frame is stereotaxy started at that time. The next step to improve these treatment techniques were the introduction of the filter-free technique in 2014. So we have the IGRT three-dimensional Chromium positioning, and we have with the flattened filter-free means a very high dose, much higher dose for the delivery. So we have we have the same margins that we had with this classic mask, and we have a limitation per fraction. The treatment time at that time were 19 minutes, and the beam on time were 7 to 8 minutes, based on the delivery time. And we are dealing with a classic with a classic SRS single dose. And from from a while, after a while, we sit down and analyze the standard treatments under the aspect of minimizing the interfraction motion versus the application time. That means, you see, this is a standard head and neck case, a standard breast case, another one, a standard prostate case, a standard rectum case, a standard lung case, and you see that we are including the cone beam CT. We are in a range of 6 minutes. We have the anal case here. We are at 9 minutes. So we are another pharyngeal case. We are below 10 minutes of standard treatment delivery times, or if you have the normal standard cases, we are below in a range of 4 to 5 minutes. So you can, and we decide to say, okay, for these standard treatments, we are using standard patient positioning devices for the treatment planning CT and for the treatment, doing for each fraction a cone beam CT for the 3D positioning, and then we had this is our approach up to now. A few years ago, we had the what can you do to improve these standard treatments, and we have introduced the CRAD system for the SGRT, surface guided radiation therapy observational, and we found that we can improve the positioning of the breast treatments and a lot of other treatments as well, lung treatments, by using this SGRT device. And there is also a paper out how to improve this this observation, for example, for a kind of open mask from the closed mask. I would like to explain that in our, I come at the end to our clinical research, and we have invested a lot of time in find out to overcome the limitations in treatment on the treatment delivery, and these limitations are the dose rate, the leaf speed, and the gantry speed, and therefore we made a lot of evaluations regarding after we introduced the FFF technique. We make we invest a lot of work to evaluate these things, and you see here you have a moderately lung treatment, 5 times 12 gray with 1 VMAT arc, and we are coming at the end to a beam on time of roughly 2 minutes and a delivery time and we delivered 2,280 monitor units at the time, and this is only possible with and you see it here, the intrafractional movement. The motivation is the breathing movement, the motion of lung and liver tumors, motion artifacts in CT images for planning and cone beam CT for positioning, difference between planning and treatment due to breathing pattern, and the big ITV volumes for compensation. So I think you know this was the reference part to introduce by Steppenwode to introduce the movement of the parts of the lung. You see here they made a grouping from millimeters and more than 15 millimeters, and therefore you know this you could compensate for breathing compensation, and we decide to go with the breath hold, deep inspiration breath hold for these cases. And the workflow is you make a planning CT in deep inspiration breath hold, you do your contouring, you do a treatment plan, and then you deliver in deep inspiration breath hold. And we observe this in addition with the CIRT system. The delivery times are for the FFF, and this is important. The delivery times are only comfortable for the patient if you have this short and with the high dose rate, it's short delivery time. And you see here, we have a paper out that the Saber image-guided Saber treatment could be delivered and applied within a 15 minutes. And this is, and then you have a comfortable situation for everybody in this with this deep inspiration breath hold approach. This is how it works. We have a 3D patient positioning here, and of course, this has a consequence for the resulting margins. Of course, yeah. In that case, our PTVs were for breath hold as a GTV plus 5 millimeters in radial direction, CTV plus 10 millimeters in craniocaudal direction. And if you are using treatments only by STRT, observing by STRT, for example, breast treatment, you have a PTV, GTV plus 8 millimeters in radial direction and the CTV in craniocaudal direction. And the doses were treated for peripheral lesions, 5 times 12 gray, central lesions, 12 times 5 gray. And if we are using a immunoboost, we have 3 times 8 gray. So we are treating up to 2 to 4 lesions at the same time. And we found out everything what we have done in the past, we try to evaluate, and we evaluate that if we are doing a treatment in breath hold technique, we have a very stable situation as well in the abdomen. So you see here a 7-field DMLC FFF 10 MV 10 times 5 gray liver treatment, and you see here a right atrial gland, that's a 10, also a FFF 10 MV 4 times 5 gray. Yeah, sometimes at LinkedIn, I try to explain how important and how difficult it is to have the whole chain working to minimize your margins, and there you have to work on that, and before you have it established. And sometimes I've found it.
Sorry to disturb you, sir.
Sorry.
You have 10 minutes, sir. Thank you.
I know. Yeah. So sometimes at LinkedIn, I see only one slice of a treatment plan, and people are surprising that they were able to make those complex shapes. And in that case, I think hopefully they have in mind that there is a lot of work that you can apply those shapes in such critical areas. Yeah, what is our medical clinic research? The optimization of the treatment delivery times. You see the limitations where I pointed out this, where the leaf speed, the gantry speed, the dose rate, the FF mode, and the FFF mode. You see the increasing number of the increasing treatment times. And when we try to work with the machine in a research mode with a linear accelerator, they were able to have 3 RPM. At that time, the halcyon comes out with a gantry speed of 4 RPM, faster leaf speed, and a bit lower dose rate. But this is, I would point out that this is an area where we went to. And you see with the 6061, you have a third in the third edition. This strict 1 RPM was released, and you could try it. And I hope you can see these two videos. On the left-hand side, there is an cone beam CT in fast gantry mode. You see these are at 23 seconds, and in the right-hand side, you see there's a treatment of a SBRT 12 gray fraction dose within 1 minute. So this is what we say. Okay, when you are going in the direction with linear accelerators, it's the same. If you are able to put this in a clinic released version to a linear accelerator, you can treat this SBRT treatments. You have, let's say, 1 minute for patient positioning. You have 2 minutes for 12 gray. So you can apply this below 5 minutes. You can treat SBRT treatment below 5 minutes. And this is what you are seeing with the health. We have own experience in image with AI based on our own image data, and this, I think this is important, and also a hint for somebody who would work into AI with AI projects. And it's important that you use for this train the algorithm. And this is what we have done. We have structured data available, and we are using. We have evaluated this approach that all the stereotactic treatments can be done by primary MR images, and the treatment planning is done on a synthetic CT. And this is the approach how we train the algorithm by our own data. You see here, this is CT, a cone beam CT, and this is synthetic CT. This works. I would explain this works also for CT and cone beam CT data. It works for cone beam CT data. You can have a synthetic CT out of cone beam CT data and out of MR. We have experience in adaptive radiation therapy based on linear accelerators. We have a paper out on that. This got awarded by the 21st Asian Congress of Medical Physics. The future requirement, this is what I see, the requirements for medical physics are also, this comes out today, the IFAM investigate the role of medical physics in clinical trials. And you see, you have the roles, responsibilities, skills, and knowledge are key factors for the design. So the question, what is the role of medical physics in the future? Right now, most of the physicists are concentrated to treatment planning. There are some support of AI modules to support the image segmentation, but I think in the next few years, this core process, treatment planning, will be increasingly automated on the base of AI. So, what are the future requirements and working with and in a team to integrate on the integration of genomic and radiomic data into clinical data for radiation therapy? This is why I include the photon counting CT example. The present situation is today we hit the start button for replacing all our 6 linear accelerators. So they were installed 2012, 2004, 2010, and the whole clinic, and this is a proof to the hospital. This area will be replaced completely by a new area. So our actual situation is what improvements and progress do we want to achieve with the re-equipment of the the radiotherapy department, while replacing the LINAC and the PACs will be renewed during the replacing the LINACs. We must take into account future infrastructure of the facility, and for a maximum benefit for radiotherapy, the oncology information system must be integrated into the central infrastructure. And this is absolutely must defined for the tender of the PACs is the viewer of the PACs has to be read all the necessary information by for given by the journey of a cancer patient. And this is why one thing I'm engaged in some projects from the German Academic Exchange Service. Here you see two candidates from the two scholarship holders from Sri Lanka. They had no practical experience with intensity modulated treatment. And then we started with they should try to write the first digits of their name. And this is how they finished. And I think they made it fantastic. Thank you for listening.
Thank you, sir.
Any questions so far, or is it?
I'm quite grateful for your time, and you have give a very good presentation, cover all the aspects of modern radiotherapy techniques, and I'm pleased to have Dr. Faiz is with us, and he also have joined your presentation. That's your fulfill your wish as well.
Yeah.
Sir Steve.
Okay.
Anybody have any questions? You can ask or to Mr. Volker. Participant can unmute themselves to raise the questions. Okay, we highly appreciate your presence, sir, Mr. Volker.
Yeah.
Would you like to say something to Mr. Faiz? He is with us, or if not, then we will continue with our.
I highlighted at the beginning of my presentation that
we can't hear you, sir.